First of all, a very good afternoon to all of you. I would like to extend a special warm welcome to Professor John Wong, the Chief Executive of NUHS, Professor Chia Ki Sing, the Dean of Swan School of Public Health, distinguished guests, friends, colleagues, staff, and students. Very good afternoon and welcome to the first Public Health Thought Leadership Dialogue for 2016, presented by the Swan School of Public Health. Today's topic is on progress in outbreak preparedness, the tasks ahead. I would now like to welcome the Dean of Swan School of Public Health, Professor Chia Ki Sing, on stage to say a few words and to introduce our special speaker for today's session. Professor Chia.
Thank you very much for coming for today's Public Health Thought Leadership Dialogue with my very good friend, Professor Peter Piot, Director of the London School of Hygiene and Tropical Medicine. The London School and our School of Public Health have been in the close strategic partnership right from the start of our school. In fact, Peter was so much involved with us. In fact, he was involved with us even before the founding of our school. You know? Now, in addition, the school, since the founding of the school, we have been organizing public health thought leadership dialogues to address complex public health and global health challenges facing us today. Moving forward, we hope to expand the output of these dialogues into the formation of think tanks, production of white papers, and global health leadership training programs. To that end, I would like to take advantage of today's session to announce the launch of our school's Leadership Institute of Global Health Transformation, LIGHT for short. And Professor Lee Hin Peng has agreed to be the director of LIGHT. He will be identifying global health issues that are of relevance to Singapore and invite distinguished visiting fellows to work on these issues. In addition, LIGHT will also organize leadership training programs in the region as well as in Singapore. For this year, we have programs planned for the Philippines, Cambodia, and Vietnam. I believe LIGHT will strengthen the global health trust of our school. So it's very fitting that this afternoon we have a global health giant for today's session. Professor Peter Piot is often known for his discovery of the Ebola virus in 1976, for his outstanding work as the founding executive director of UN Aids, as well as his role as Undersecretary of the UN. He has perfectly integrated the biomedical, public health, and the political aspects of infectious diseases. But Peter will not have accomplished all this today if he listened to his mentor when he was a young man. Because he was told not to go into ID research. He was told that it's a waste of time because we have already discovered antibiotics. But perhaps he was actually inspired by his favorite comic book hero, Tintin. In fact, if you look up PubMed, there's even a publication on Tintin. There's a research paper on Tintin's travel traumas. The conclusion of that research paper is that Tintin is highly resistant to trauma and not subjected to the usual travel-related illnesses. Now, if you have read Peter's book, No Time to Lose, you could actually come to the same conclusion about Peter. Highly resistant to trauma and not subjected to the usual travel-related illnesses. Peter and his wife Heidi have been with us for the last couple of weeks. We have been having very productive and a lot of fun sessions together. And I look forward to this afternoon that will be both productive and fun. So he'll share with us his thoughts on progress in outbreak preparedness, the task ahead. Peter?
Thank you very much, Ki-Seng. Good to remind me of the ultimate Belgian hero, Tintin, and who was really also an inspiration for me. And not knowing I have some of the original albums because I grew up with him, not knowing that they would now be something I could sell in difficult times. But also, congratulations on being on the front page of the Straits Times today for something that is, by any standard, also becoming an epidemic, and that is diabetes. It is probably not of infectious origin, but by any definition, when you see an increase in cases all the time, it's an epidemic. And so I would not like to pretend, because my interest is in infectious diseases, that in today's world, the major burden of disease, except for sub-Saharan Africa, is in chronic diseases and related to, increasing life and so on, which is a good thing, of course. However, there are obviously major infectious diseases, and the problem is not solved. And indeed, when I graduated, or before I graduated from medical school, the advice of my professors was unanimous that there is no future in infectious diseases. Because we have antibiotics, we have vaccines, sanitation, and so on, and that's all true. Major progress is made. But even if we would have even better vaccines, and if we overcome antimicrobial resistance and so on, there still will be infectious diseases and outbreaks. So first point I'd like to make, and I'll start with really more as an introduction to our panel and put some points on the table, but that overall the burden of infectious diseases, certainly in Singapore, but also in a growing number of countries in the world, is fairly limited. However, they can be extremely disruptive. Last year, the last 2 years, Ebola was in the news in West Africa. Well, it shut down the entire economies of 3 countries for 2 years. 3 countries that were struggling because of their past, civil war, corruption, and so on, but that were really getting out of that these difficult times, and then with Ebola it was all over. But we've seen it with SARS here, something that we didn't know that existed, caused over 700 deaths, and $40 billion US dollars of economic cost, including about 400 million US in Singapore. So they can be highly disruptive and costly. Disruptive also because they can shut down a service in the case of an epidemic, for example. We see it here and elsewhere. It can be either hepatitis C in renal units, or it can be untreatable, gram-negative septicemia and infections and so on. We also should be clear. I mean, many we can predict, and we know a lot about infectious diseases, but in my short life there have been like tens and tens of new viruses and bacteria that emerged, that were discovered. Some were already affecting people, others not. And that will continue. And one of the main reasons is that, we as a human species, we put a lot of evolutionary pressure on, these other living organisms, bacteria, viruses, parasites, and so on, by our mere existence, and population growth and so on, but also obviously because of what we try to do to defend us from ourselves. Now, before going into epidemics, it's always useful to go back to basics. And this is from the very basic and simple formula from Roy Anderson, who was a frequent visitor here, and Robert May, trying to define the dynamics of the spread of infectious agents in a population be it human, people or animals or whatever. And because this is how you can define an epidemic. And it's the RO stands for the reproductive rate. And it comes down to the fact that if, on average, someone who is infected with a particular organism infects on the average more than one person, then this is a building up of an epidemic by definition. So even in the case of diabetes and obesity, there have been some papers showing that from a social networking perspective, one can also speak of, consider it as a contagious disease. But here it's of course different. And there are three main determinants. There are many more. We should also recognize that. But the three basic ones are probability of transmission, which can be very high, in the case of measles, for example, or it can be pretty low in the case of Ebola, where you need really close contact, and hence the importance of the healthcare setting or the care setting, the number of contacts. In the case of HIV, you can be healthy for 10 years, 12 years, while living with it, while being infectious and infect lots of people, and that's the D, duration of infectiousness. So all this is a very useful tool to think about a particular outbreak or infection when you are confronted with it. Now, earlier this week, I had a very interesting brainstorming, I should say, at the Ministry of Health, and where we were talking about detection and response to unusual infections, unusual being not something that you see every day. Although some of these infections can be around permanently. The big elephant in the room is really the healthcare setting and settings of social services, be it kindergartens or crashes or institutions or houses or communities, or for the elderly and so on. Because, of course, they're doing a lot of good, hospitals and so on, we all know this, but they also are fantastic opportunities for a microorganism to infect more people. Particularly when we have lots of people concentrated in the same place, when we have invasive procedures, when we have opportunities for contact either directly between people, indirectly through fecal-oral transmission, or simply, as we all know, for us who work in hospitals, just simply through hands. Something that was already shown in the 19th century as being absolutely a very important vehicle for transmission of pathogens. And just by hand washing, the historic observation, Semmelweis, that you can reduce maternal mortality through reduction of sepsis and of infections during delivery just by washing hands. But this elephant in the room is something that we should never forget, because we can talk about the big ones all over, but that's the most immediate one, I think. Secondly, and I try to go through some taxonomy of where we are. Secondly is about infections that are in the community, are simmering, or where we have lots of carriers, but now and then can give rise to epidemics. A classic example is meningitis and septicemia through meningococcal carriers. I mean, we don't always understand what's happening, but it can be an enormous challenge for public health officials, for authorities, for politicians, for parents. When you have 2 cases of meningitis in a community, meningococcal meningitis, is this the beginning of an epidemic? Is this just a chance observation or not? And these are extremely difficult decisions to take, and we have to see. Another example that you had here has to do with, like group B strep. In this particular case, group B strep is all over. But in a particular case can be amplified, in this case, by food. And thirdly, we have what we could call external threats. This what happened with SARS. Ebola far away, MERS, and so on. And then lastly, the black swans, you know, things that happen that kind of nearly come out of the, drop out of the sky, which has been the case so many times now, and I'll come back to all of these very briefly. Now, I won't go into detail because I think we will discuss it later on to nosocomial infections or outbreaks that are amplified or triggered by, in the healthcare setting, in social services settings and schools and so on. It's a very well developed science how to control it, and it comes down really to rigorous discipline. But there's another issue that has now come to the forefront, not only in medicine, in public health, but also at the political level, and that is antimicrobial resistance or you know, resistant infections. They've always existed, but it has come to what is considered a crisis point, and it's now on the agenda of the G7, G20, and a special session of the UN General Assembly is in the make on resistant infections, and it requires a global approach. Of course, we can do a lot at the local level and reduce the development of resistant infections, particularly in the hospital setting, but there are global aspects. And here, when you just look at the worldwide increase in antimicrobial resistance through very commonly used antibiotics categories, fluoroquinolones, cephalosporins, third generation, and aminoglycoside, you see there is a continuous increase. Now, this is not very exact science. I mean, it's a cumulative big data, but the rise is absolutely undisputable. We've seen it with multi-drug resistant and extremely drug-resistant tuberculosis. We're seeing it not far from here with artemisinin-resistant Plasmodium falciparum, in other words, malaria, which I'm very concerned about because it's growing and growing in on the ex-Golden Triangle in Cambodia and Burma and Thailand. And when this will hit the region in the world that is most affected by malaria, in other words, sub-Saharan Africa, it could be a real disaster, killing lots of people, as was the case in when chloroquine resistant appeared in exactly the same area and spread all over the world. And I'm really dismayed that there isn't a worldwide emergency and a plan and as much money going into controlling this as has been the case for Ebola, for example. And it is a very complex issue because lots of interests are at stake, from the criminal side of people who make counterfeit drugs to prescriber behavior and so on and so on. Now, it's difficult to predict the future, but it's safe to predict that we will see an increase of outbreaks that are no longer limited to a small community or even one country, but that become really global, regional, or global. And here you see the a very simplistic also picture of the increase in the incidence, new cases of dengue fever, and of international travel, of course, with very different, fortunately, scales. On the right side, we are billions of travelers, and on the left side, a few millions of infections with dengue. But that's really one of the reasons also that Singapore is very vulnerable. And to dengue, of course, because it's transmitted by Aedes by mosquitoes. And when even Japan, in one of the most popular parks, where the Japanese take millions of pictures of cherry blossoms, every year had to be closed because of dengue in Tokyo. So this is an illustration of the growing vulnerability of the world through mobility, but also partly climate change and so on. Other aspect is, as I mentioned, is that that in today's world, a problem that's occurring thousands and thousands of kilometers from us can mean a problem for us. And take MERS. This is caused by a coronavirus of the same family as SARS. It started in the Middle East, and it's camels that are the source for people, and has been endemic and with peaks in Saudi Arabia and the Gulf states with cases that occur in the community, then are hospitalized, and then causing hospital-centered outbreaks with lots of cases and fatalities among healthcare workers. But one day, last year, now in 2014, a Korean businessman flew from the Gulf to Seoul, and there triggered off an epidemic. And you can see how one person can really be at the source of major infections. When I turn this around, it means also that helping to control epidemics far away is what economists would call a global public good, because it's in our interest. It's not only good and useful for the people in these communities, but it will protect the rest of the world also. And that is the rationale from an international, from an economic and a political perspective, why we should really provide that kind of support, and it's in the interest of all countries. That's the global dimension, and that's something that is an economic and political rationale, and there's of course also a humanitarian rationale. Now, the newspapers are full at the moment of this other new virus, but it's not a new epidemic, but it's not a new virus, the Zika virus, which was discovered already by accident in 1947 in Zika, which is a forest not far from the Uganda Virus Research Institute in Entebbe on Lake Victoria in East Africa. And it was discovered during studies on yellow fever epidemiology and spread in the forest. And they found the virus, but it was a virus without a disease, and didn't really know what to think of it. And then later on, cases were identified, epidemics occurred, and to make a long story short, we now have a major epidemic in Brazil, in Latin America. In Brazil alone, over 1 million people have become infected. But the infection, the disease, the illness caused by it is not that bad after all. I mean, it's a milder form of dengue, if you want. And it's also the same family of a flavivirus. But what is very, very worrisome and was first observed in French Polynesia 2-3 years ago is that it appears to be associated with microcephaly in babies born to women who were infected with Zika virus during pregnancy. That link is not yet 100% proven. In Brazil, for example, there are over 4,000 cases of microcephaly that were reported, but like only half are actually were confirmed as having microcephaly, because there's a kind of a Gaussian distribution of the the head circumference. But those have microcephaly. There are now a number where Zika virus was isolated from amniotic fluid, in one case also from the brain, in the case of abortion, which in Brazil is illegal. And so studies are being done at the moment to demonstrate beyond doubt that it is caused by Zika virus, which would not be unusual. We've seen it with other viruses like rubella and cytomegalovirus, toxoplasma, another parasite. And the question that I have, let's assume that that this is proven, are there other, perhaps milder or immediately milder forms of neurological and other damage that can be caused by a Zika virus infection during pregnancy, as we've seen with these other viruses that cause this kind of congenital affections in offspring of women with acute infection. When is the risk, etc.? It's because of this association, and also perhaps with Guillain-Barré syndrome, the neurological syndrome, which we find also after other viral infections, even after regular banal influenza, that made a committee, a WHO committee, chaired by someone very well known here, David Heyman, Professor David Heyman from our school and also from here, to conclude that this was a public health emergency of international concern, which is something that WHO rarely uses. And so that's an example of that. It's not just because of the infection itself, but the sequelae and the consequences. There are huge challenges here, not only trying to prove beyond doubt that this causal relationship, but also to control it. And since this is a vector-borne disease, that's not so easy. You can't eradicate, you can't eliminate mosquitoes, and it's very much linked to poverty. It's particularly the people living in slum areas with a lot of stagnant water and so on that are victims. But also we are lacking good, inexpensive point-of-care diagnostic tests, serological tests that are specific enough and distinguish past Zika virus infection from dengue and chikungunya virus infection. And also the race for a vaccine has started because indeed, if this is an infection that causes these congenital malformations, a vaccine will definitely be important and would be used on a large scale. Just think of rubella vaccine, something that has really led to the basic elimination of rubella-associated congenital abnormalities. So it's an example of something that is new. Will it come to Singapore? I'm sure it will. It will go all over the world. And it's a matter of time. But at least here one has you have this experience of dealing with dengue, dealing with arthropod-borne viruses. Now, without going into more detail, but basically all these emerging infections or epidemics are zoonoses. They are coming from animals. Even to a certain extent, antimicrobial resistance, although that's a man-made disaster. But when you know that the majority of antibiotics are used in agriculture for growth promotion, chickens and cows and pigs and so on, fish also, lots of antibiotics are used, and they're used at subtherapeutic levels, which is wonderful from the perspective of the pathogen. That's the best way to select out resistant organisms, but also we have closer and closer contact with with animals that are carriers of viruses. Now, on the left side is a chimp, so HIV, which is the largest new infection that appeared since the Spanish flu at the end of last century. Started with a report on 5 gay men in California, and cumulatively has infected now 80 million people in the world, 30 million deaths. Sorry. Who would have thought that would be possible, something very old-fashioned sexually transmitted? And then you see a bat there, so that's the virus reservoir for coronaviruses, we think, but also for Ebola, although that's not fully proven yet. Now, there are drivers of zoonotic diseases and that are becoming stronger and stronger in today's world. And I won't go into detail of all of them, but I think they're relevant also for Singapore here. I mean, international travel and trade is just a fact of life, and is spreading and is helping to spread these infections. What used to be a local issue, it becomes global. Same thing is true with food production. I mean, you import most of your food. I remember a picture, it was in Science magazine, of a salad in the US, and it indicated the origin, the country of origin of each piece of the salad. Well, it was the United Nations in a plate. But it's also the production of food which has become far more concentrated. When a farmer had a few chickens infected with salmonella or a virus or so in the backyard, okay, that's bad for the farmer, bad for the chickens and so on, but that's it. Today, that can give rise to major outbreaks. We have also the demographics, population growth, climate change, which contributing, and so on. So we can safely predict that the risk for outbreaks is going to increase. On the one hand, as I mentioned, because of our medical practices, and the older the population gets also, let's not forget that pneumonia is the second or third cause of death, immediate cause of death in old age, but also the outbreaks. And then we have the risk for global outbreaks. This is from a paper in PLOS Current Outbreaks. There's now a PLOS for that, already several years, TLOS. And there are, I think it's a bit not up to date, but with elevated risk for disease outbreaks. And I think here in Singapore, you're really in the middle of several high-risk areas, be it for viruses or also for bacterial infections and so on. Now, the risk, the vulnerability is increased, but I think also we're far better equipped than before to deal with it. And that's the good news. But it doesn't happen spontaneously. It requires really an effort. And I would see this as a typical function of the state. It is to protect against what hopefully will be rare events, but can be very disruptive. And it's not, it's like having a fire brigade. You don't set it up when some house is on fire. You need that all the time. And you hope that they will never have to go out for, that no house will ever be on fire. But it happens now and then. But the first, challenge is prompt detection. And how do you know that there is an epidemic coming up? Be it in in the ward, in a hospital, in the community, in the world. And here the traditional way is fairly passive notification, which of course is necessary, but is too slow and doesn't pick up beginning of problems. That is something that where we have to go beyond. We have to be far more proactive. I think that one day that big data will help, but also in general they're not sensitive enough. Although a few years ago Google said showed in a paper in Nature that it could detect faster. At the beginning, this was of influenza outbreaks in the US by monitoring keywords and questions in social media and so on, and what was asked. But that didn't always work because, for example, it missed the Ebola outbreak in West Africa because there most of the questions and the keywords were happening in French and not in English. So, but that's a matter of time. But also, we are not there yet that we can use this big data and from clinical records and reporting. So that's something, but that's for the future, I think. That combined with machine learning should give us, particularly for hospital outbreaks, a good, a very good vehicle. Laboratory data are key. Certainly in countries like here where the labs, the microbiology labs are used a lot, our techniques are much faster, more sensitive. The problem though is that the dots are often not connected. That, particularly in the beginning, let's assume that there are 10 labs in a city and that normally a particular pathogen occurs like once a year. So if each of the 10 labs finds that particular pathogen around the same time, they may think, okay, that's the one of time of the year, and whereas there are 10 already. So that, I think, requires some quite active intervention. And there are, in the UK, we have, through Public Health England, very active laboratory surveillance, which I think is really very useful, and the same is true in some other northwestern European countries, the Netherlands and Sweden and so on. But in most countries, it's not the case. So connecting the dots, I think, is a big challenge, and with today's IT should be really important. And then I would say, in a very old-fashioned way, don't ignore clinical anecdotes, or someone say, look, I've seen something, and that really, okay, one side of me always says that there was in my training, is unum est nullum, as they say, one is nothing, one case, but it's the first observation that is really extremely important, and that's where I think it's so important also, for example, that a clinical microbiology lab is in the hospital, and when the lab sees something, you can go directly, you can call, or vice versa. And I don't know about Singapore, but in Europe and in the US, clinical laboratories are more and more distant from the actually patient care, and for economic reasons. And that kind of immediate feedback and the personal touch is no longer there. Now, we also have fantastic tools today that we didn't have before, and that is genomics. And that is, we can now type and characterize pathogens to the individual, just as we can do for people. And it's not important what's in there, but it really helps us to say that this is an outbreak of people are linked with the same organism or not, or these are independent facts or not. And whereas in the past this was extremely expensive, took a long time, today we can type these organisms very, very rapidly. And again, this is something where we have to connect the dots. This is from the Ebola outbreak, and one of the questions was that we saw after the outbreak, the epidemic was declared over, cases popping up again. The question was, is this reintroduction or is it something else? And we know today it was something else. It was sexual transmission, and we can show it's the same, isolate, and so on. Second point after the detection and early detection is we need a framework for outbreak preparedness. This framework is our fire brigade type of framework, the insurance in a sense. And it has to deal with known infections that you know about, you have the information. One of the issues is what is a trigger, what is a threshold before when we can say this is abnormal, this is an epidemic, and what is kind of normal variation. And that requires a combination of good baseline data, but also an analysis of what the potential is, real-time mathematical modeling sometimes, and learning from experience, because it is a judgment call. Then there are new threats, and some of them are unknown. So you can't have a system that is prepared for everything. But the better your system is, the better you will be prepared also for those unknown. It should be an all-of-government, endeavor. It's, of course, the Ministry of Health and the health community, the medical community, the medical schools and so on are extremely important. But when it comes to a serious outbreak, it is for everybody. Think of like dengue when you have vector control. There are issues of food security in other areas and so on. And communication is very important because in the case of some epidemics, managing the rumors, managing sometimes the mass hysteria is as important and can be as complicated, if not more complicated, than actually dealing with the epidemic. We saw that in the US with Ebola. I mean, they had in 2 cases or so, you know, and that the cost of just the managing the what was close to mass hysteria was incredible. And my third point, and that's the last one, for coming to some conclusions, is that we need to expand the resource base for that. It is the capacity of the health system has to deal and is absorbed mostly by now chronic conditions. And it's already at full capacity. And yet when something is added to that, how to deal with that? So that requires plans, but that's the framework. But it also requires that we can count on a bigger resource base than the limited, by definition, limited number of individuals with infectious disease and outbreak containment expertise. And it's government, of course. It's a responsibility of the government to protect its citizens. It's Ministry of Health, etc. Academia has a lot to offer, and also in between. And I would say, think One Health. One Health meaning not just in human primates that we are, but also all other animals. And that's a dialogue that is rarely happening. And then media monitoring. So in a number of countries now, in Europe also, we have this kind of public health, classic public health, establishment and institutes, but also formally linked with academia. And now a few points before ending, and that is that what we are seeing is very interesting in the world today. I would say that the 2 defining health challenges of our time have been, at the global level, have been the AIDS epidemic. It generated for the first time a global movement and put health at the top of the world's political agenda in the Security Council of the UN and the General Assembly and the World Economic Forum and what have you. And it really gave birth to what we call global health now, a term that did not exist in the last century. And the last century is only 16 years ago. But now we have Ebola also. And again, nothing new. And after all, it killed 11,000 people. But that's in 3 countries over 3 years. That's not that many. More women died while giving birth and children while, for untreated, because their malaria was not treated and so on, because the health system collapsed in these countries. But the fact is that it, with Ebola, global health security and global preparedness for epidemics and pandemics is now at the top of the agenda. G7 summit last year in Germany, it was one of the main issues. It is also as part of Japan's agenda, which they have now the presidency. The G20, which normally only discusses financial matters, now also is dealing with it. And there is a momentum that is growing. Part of it is also to do with the failures of WHO, the World Health Organization, to adequately respond. And there have been a number of panels. I chaired one with Harvard University and London School of Hygiene and Tropical Medicine on the global response to Ebola. There was one that WHO organized. The United Nations itself had a high-level panel chaired by the president of Tanzania, and the Institute of Medicine, the National Academy of Medicine of the US also produced one. And their conclusions are all very similar, and that is that our global system is not fit for purpose at the moment. It has not followed the fantastic, globalization, mobility, and so on, and WHO has not received the resources that it needs to deal with this, and needs also to reform. And I think this is a story to follow, because this year some of these reports will be acted upon. And this is the beginning of the executive summary of the high-level panel, which was released about a week ago, on the last Monday. and it's called Protecting Humanity from Future Health Crisis. And this high-level panel, which is made up of prime ministers and presidents and so on, and experts, says the high risk of major health crisis is widely underestimated, and the world's preparedness and capacity to respond is woefully insufficient. This is not only for low-income countries, for African countries. The diagnosis is that this is the case for about every country, and so it is now coming to the right levels. And to end some lessons here, these are my lessons from dealing with Ebola, dealing with AIDS in the world, but they can be applied for many things. One, as I mentioned, that emerging infections will continue to rise from animals. This will continue, and you can expect the unexpected. So there are unknowns, and and we have to take that into account. And one day we will have a mega influenza pandemic when we don't know. I think what's important also is that our response should be driven by science. A lot of the responses have no evidence base. I mean, particularly when it comes to testing, screening, closing the borders, and all they can do more harm than good. But that's the political knee-jerk reflex. And so that the government is seen to do something. Like when there was SARS in Canada, there was one person who traveled Hong Kong to Toronto, and it gave rise to, an epidemic and some deaths. Canada installed strict border controls and so on. They screened, I don't quote me on the figure, but I can't remember. But how many cases did they detect? 0, at a huge expense. Something that the money that could have been used much better for other reasons. And the same is true for Ebola now, and so on. So it should be driven by evidence, of course, the medical care and so on also. It's not always easy because in many cases, particularly when there's something new, the evidence is not there. And look, for HIV in the beginning, many countries were restricting travel for people living with HIV, imposing testing, and so on. There's still some that do that. But in these days, there was a known. Today, we know that that doesn't make sense. It is not really protecting any country, and HIV is everywhere inside. So that's not going to make a difference. And I hope that we will soon have a time where no country will have this kind of policy. But also, I think human rights are an important driver. And that was the case, for example, when it came to access to treatment for people with HIV, with AIDS, where we, since '96, we had a very effective therapy, but was extremely expensive, so we had to really work very hard to make that accessible to everybody. Thirdly is the central role of people affected. And what do I mean by that? By that I mean that we always have to listen. We know what is the science out there, and sometimes, not always, look at Zika, we're not so sure, but we also have to talk to people, to listen, to see how they look at it in order to be highly effective in what we're doing. So that's really important, and this is where the social sciences also come in, but also marketing and so on. Fourth, good politics, bad politics is the title of an article that Heidi published once, and that is politics can make a huge difference about making the right decisions, putting the resources where they have to be, and so on. Bad politics, an extreme example that we saw in South Africa during the beginning of the AIDS epidemic, where the President Mbeki denied that HIV existed and so on, and it delayed by many years the introduction of life-saving antiretroviral therapy. Good politics requires courage and have to do. We need specific mechanisms for infectious disease control, finance, and R&D. I think that's also a lesson. That's my fire brigade, and it's an insurance on the future of a country. R&D also, just one point, because it came up in all the reports on lessons from Ebola, and that is that where there is no market incentive, where there's market failure in other cases, that we will not see the development of vaccines. A vaccine for Ebola, no company is going to make money out of that. And for other similar infections. So there we're working now with a number of companies, governments, The Gates Foundation, the Wellcome Trust, Jeremy Farrar, well known here also, is leading some of these efforts, and that we can come to a public-private partnership that will provide a strong coalition of those who prepare, make the vaccines, develop them, discover them, and those who can have an interest to make them. And I hope that Singapore will play a big role in that. And lastly, I think health systems and public health systems is strengthening. I mean, health systems, we know, health service delivery, the hospitals and so on, but public health systems is really the capacity to deal with it at a global level. And above all, we need to act promptly. This is one of those areas where the slogan, act now or pay later, is really true. Because of the nature of infectious diseases, once you have a case of infection, it can give rise to more. So the sooner, the earlier you intervene, the more cases you prevent. And that's a very strong economic argument. So no time to lose. Thank you very much for your attention.
Many thanks again, Professor Piot, for that very inspiring talk as a way to kick off this dialogue session. Just taking a bit further from the analogy of comic books, I mean, seeing the integration of multiple abilities and needing people to work together, it seems like X-Men would be the literature of the future public health experts in the world. Now, as I've spoken, the dialogue session will continue now with the next segment. And for that, I would like to welcome on stage Associate Professor Su Li Yang, the moderator of the discussion. Associate Professor Su is an infectious diseases expert who has spent the last decade researching the epidemiological trends and consequences of antimicrobial resistance in Singapore as well as in the region. He is currently program leader of the school's Antimicrobial Resistance program, as well as the director of the Singapore Infectious Diseases Initiative. Associate Professor Su, please.
Thank you. I guess time is moving on. And I'd just like to invite our other eminent panelists on stage. They are Professor Liu Yisin, Professor Paul Tambaya, and Professor Vernon Lee. Please come up and join Professor Piot. What's going to happen next is almost like a panel show. Our other panelists will be given a short period of time to present their perspective and comments to what Professor Piot has mentioned, and then we'll open this to the floor for further questions and for any answers from Professor Piot. So I think the first person that we get the comments is Professor Liu Yisin. Professor Liu is, as you all know, the director of the Institute of Infectious Disease and Epidemiology at Tan Tock Seng Hospital. She's also director of Communicable Disease Center for the Ministry of Health, and she has seen all the outbreaks that's happened in Singapore from the 1990s until now, and she has survived all of them. So I'm sure she has very good and valid comments. Professor Liu.
Thank you, Liang. And thank you, Kisings and School of Public Health and UHS for giving us this opportunity to come here face-to-face, meet up with Professor Peter Piot. And I'd like to thank you for the very interesting, very encompassing kind of presentation this afternoon. It is a very broad view, and I thought perhaps I would just zoom in a very specific angle. I am clinicians, so we have the primary responsibility to our patients. So I think what I would do is that I would take the outbreak, the context of the outbreak from the hospital setting. Yep. And then we use the hospital to engage at a different angle. One of the things I realized over the years is that when people keep harping on the fact to say that infectious disease respects no borders, a lot of times I think we are thinking the borders as being Singapore versus Malaysia versus different countries. But in actual fact, truly there's no borders, because even within the healthcare system, we are seeing this interchange of bacteria, bugs, and outbreaks that's happening within the entire healthcare system. So we recently had the experience with hepatitis C in one of the renal units in Singapore. But at the same time, we're asking ourselves, is it just restricted in the hospital? Or it is hospital and beyond. Our hospital, entire healthcare system is so integrated that anything happens in the hospital, we could be shaking hands with step-down care facilities. And that could be, in the community as well. So one of the things you mentioned about amplifier, so to me, in my mind, is that what puts healthcare in a amplifier positions? One of the things I believe is what we all have this thing in mind, which is the MDRO, the use of antimicrobials leading to multi-drug resistance organisms. And one of the things I'm asking myself is that some of the outbreaks are very visible, high impact. We see it, we feel it, we recognize it. But there are a lot of outbreaks out there, whether it's in the hospital, in the community, it's ongoing, but it's either we recognize it, ignore it, or we decided not to pay specific attention to that. So I thought, just from the hospital perspective, within the hospital we do understand that, we need to beef up and we have issues within the hospital, but it's important for us to be able to link up with the entire healthcare facilities as well. I think perhaps I will just give one very explicit example of hospital and beyond within the healthcare system. Multi-drug resistance is one classical example where you can have patients discharged from the hospital with MRSA or multi-drug resistance that ends up in a step-down care. And the issue here is that we always think that it flow one directions, but actually it's not. It could flow in multiple directions. And we also know that in acute care hospital setting, we may not be the only amplifier. The amplifier could be a step-down care community hospital.
Yep.
And eventually these cases in a community hospital will come back to acute hospital. So the recent examples or recent experience we had with norovirus outbreak, with acute influenza, with pneumonia outbreak in the community setting, I thought that there's still a lot of rooms for us to improve, not only to deal with this huge visible outbreak, but a lot of ongoing episodes in Singapore, and I thought that will give us this platform to better assess and improve the entire healthcare system. And I believe that it is through these recognitions and willingness to improve to set up a peacetime, or rather a regular sustainability of the expertise. Only if we can do that, I think when the big one hit us, we will be able to respond in a more expedient and more effective manner. I'm just a clinician talking from the hospital setting, so I think my colleagues will likely give you a different perspective of how they look at the outbreak.
Thank you very much, Professor Liu. And next, we have Professor Paul Tambaya, who really doesn't need any introduction for those of you who are here. He's unfortunately better known as an opposition politician. But this hides the fact that he is actually a very eminent researcher, and he's got a very sharp mind, and he has a lot of experience dealing with outbreaks and infectious diseases as well. Professor Tambaya.
Thanks very much, Liang. I really liked that part when you talked about human rights as being critical to infectious disease control, but I will control myself a little bit. And I knew Liang was going to say something about Eason and myself being older than him, so I actually pulled up an article that was published the year that my mother was born. This is from the American Journal of Public Health, November 1937. And it was written by a public health physician by the name of Frank Boudreau, who was actually the deputy to Ludovic Rachman, who later went on to found UNICEF. And this was in the American Journal of Public Health, and it was a speech he gave at the American Public Health Association meeting in New York. And what was really interesting is he talked about global public health. Of course, he didn't use the word global health, because in those days it was International Public Health Office. And he says, what progress has been made in public health standards? And he says there have been these organizations, and he was referring to two organizations founded by the League of Nations, the first in Geneva and the second in Singapore. And he said these organizations have been a tremendous help in the efforts of governments to prevent the spread of epidemic diseases. This is perhaps best illustrated by the Service of the Epidemiological Intelligence Unit established at Singapore. All the important national health administrations in the Far East report to Singapore by the most rapid means, usually the cable, the movement and prevalence of plague, cholera, dysentery, smallpox, and typhus fever in their ports and within their borders. Singapore, in turn, digests and assembles this material and broadcast it from 10 wireless stations at daily and weekly intervals so that every health officer in that wide area, and that area actually extended at that time from Vladivostok in the north to New Zealand in the south, from the Panama Canal in the east, all the way across to Suez in the west, may take action based on the most recent and accurate reports. Those who are interested in this service should read recent league bulletins on the march of cholera in Shanghai, Hong Kong, and Swatao, a painful reminder that our success in preventing great epidemics is restricted to periods of peace between the nations. And that was during the Japanese invasion post the Marco Polo Bridge incident. So I thought this is very striking because it emphasizes the fact that Singapore has always been a crossroads for the world, a major communication point, a place which is actually uniquely positioned for epidemic intelligence, which has been recognized for the last 90 years. So we now have the resources, not just in terms of telegrams in those days, but with the internet, with some of the things that Peter talked about, the scientific resources, to really pick up where we kind of left off. Of course, this service, apparently it used to be in River Valley Road. I'm still trying to find the building where it was. It's one of those old buildings, way pre-war. And of course, with the occupation, everything ground to a halt. But I think certain things are still there. The human resource, the geographical location, the interconnectedness with the whole world. So I would say we should pick up on what Peter has talked about and really maybe restart something. Because again, I don't know if you realize this, but he mentioned the public health emergency of international concern. Tuberculosis was declared a public health emergency of international concern in 1993. We haven't really done very well since then. And then you had the H1N1 2009, which people said they declared it too early. And then you had Ebola, which people said they declared too late. And then now you've got Zika. So I really don't envy Margaret Chan. So she's really so she needs the information. We I think have the opportunity and resources in Singapore and in the school to really provide some of the resources available for the world to make better decisions when it comes to global public health. Thank you.
Thanks very much, Professor Tambaya. Opposition politicians get applause quite easily. And our final panelist is also very well known. Professor Vernon Lee has perhaps the most checkered career amongst the three local panelists here. He's been to the World Health Organization. He heads the Singapore Armed Forces Biodefense Force. And he is also seconded to the Ministry of Health as Deputy Director of Communicable Diseases. And he's also a faculty at the school here. So, Professor Lee.
Thank you. Thanks, Professor Piot, for that wonderful presentation, and also to my esteemed colleagues for their sharing. Actually, much of what I want to talk about actually is to build on some of the points that were previously mentioned. One is the whole of society approach, and that's something I think is very, very important for us to take into account. Something that we might take for granted in Singapore because all of us work so closely together. But if you just take a look around this room, how many of you actually know more than half of the other people in this room? I highly doubt so, but anyways, it's events like that provide the opportunities to network with like-minded colleagues to actually do something for the control of infectious diseases and also perhaps for non-communicable diseases. Interestingly, a lot of the things that we've talked about today are actually pertaining to global health security threats. And it's not just talking about emerging and re-emerging diseases. There are other things such as the effects of climate change, chemical, nuclear incidents, for example, like the radiation incident in Fukushima, that actually needs to galvanize the public health community. And when we talk about all the things that we need to do, from risk assessment and surveillance, to risk management, preventing diseases, preparing against potential threats, responding, recovery after epidemics, you can see that this is not a task just for one organization or one institution. You need the whole of government and essentially the whole of society to come together. And this is something where we have to think through how do we break down the silos that we work in and really reach out to people across the room, across the country, and across the world to try to work together to bring out solutions. The other thing I would like to then move into is this thing about black swan events, or the sort of unknown unknowns that affect us. One of the major issues that we're faced with is often making decisions in the face of uncertainty, and what we commonly call a fog of war. It's very easy, obviously, when we evaluate past epidemics or pandemics, to evaluate them with 20/20 hindsight, and everything that we criticize, whether it's WHO making decisions too early, too late, and so on, it's always done with a lot of information at hand. But when we are faced with all of these global health security threats, decisions have to be made literally on the fly, and most often without complete information. So if you look at SARS, unknown disease, we have no idea how to react to it. Ebola, known disease, we thought that we would be able to control it like we have done for the past 30, 40 years, but it turned out to be quite different. And even Zika now is declared a public health emergency of international concern, not because of the things that we know about it, but because of the things that we are yet to know about it, things like the effect on microcephaly, on Guillain-Barré syndrome. So it's actually very important to then perform exercises to determine what are best available responses to these diseases. But apart from just exercising on what we know, because commonly when we do exercises, we sort of plan an exercise schedule and we say, okay, what are the possible scenarios that could occur? It's actually quite important also for us to think about what are the scenarios that are unthinkable. I'm not sure how many of you had watched the movie World War Z, the one about zombies being infected by viruses. Actually, quite an interesting movie. Those of you who haven't watched it should actually watch it for public health value. But what was mentioned in the movie, if you recall, was that Israel actually built a protection or prevention system against zombies. And it was down to this thing called the 10th man. So they had come up with this idea that you have to have someone who's not within that groupthink to think about these unthinkable scenarios. And actually, in real life, Israel does actually have such an office. It's called a Devil's Advocate Office. And what it basically does is think about all these black swan events and ask the government or the military to then prepare for these possibilities. And that would be a very tough exercise to go through, because I'm sure that most of us would fail horribly in such an exercise. So something to consider on how we plan for the unknown unknowns and also the unanticipated. And with that and a whole society approach, hopefully we'll be able to deal with future threats a lot better. Thank you.
Thanks very much, Vernon. I'd like to open this now to the floor. Those of you who have...
Well, first of all, I agree with everything that was said. No, thank you. But now a few points on the this international health concerns, international concern epidemic. The problem is that it's an all or nothing game. Normally when you have risk assessment, you have different levels. In the case of the international health regulations, it's either there's no problem, or it's something of international concern. And that, our panel said that's absurd. You can't manage that. And so it's an extremely big responsibility with all kinds of consequences. But one could have a, 5-level scale, just as we all use for risk management. And then you can, that's much easier to challenge, to manage. Now, I think indeed that when I mentioned the health system, but also social systems and or services as amplifiers, of course, these bugs don't fall out of the sky. They come from within the community and they go back in the community. And which means that, again, just make your point also, it's a whole of society, really, management, and one needs a comprehensive surveillance when it comes to antimicrobial resistance. I mean, you can say something about it also, but we're constantly exposed to it from all sides. And it's not just in the, by doctors who may overprescribe or whatever. And so that I think is a very important lesson that we have not really internalized yet, or certainly not put into practice in most societies. Okay, there is a responsibility dealing with someone with an infection. Fine, okay, that's in a sense a relatively easy part. We know how to do that, but it's all the rest and the management of that. And I think that is really good. And then finally, I would say our standards have also changed with the years. What used to be kind of acceptable in terms of background noise and infections or the rate of infections after surgery and so on today is unacceptable. So, and that is a good thing, but that means also that we need to revise sometimes our standards, our triggers, and I know the Army usually has quite good, clear ideas of what is a trigger. You can't really replicate that automatically in open society, but still we can learn from that just as we have that in hospital. But our standards have gotten much better, much tougher, and we are now also, let's not forget, we're through our advances in science and so on. We will see infections or maybe events, adverse events in health that we know that exist, but we could not classify them, we could not manage them. And that is exciting at the same time, but it's going to make life even more complicated. And then, if you're in a country like the US, you have the legal implications, but that's another story. Yeah.
Thank you very much. Now, I'd like to open this to the floor again. And are there any one of you with burning questions or comments to make? Please introduce yourself and the institutes that you come from, if possible.
Okay. I'm Indu Venkatachalam. I'm an ID physician at National University Hospital. Thanks for the very interesting panel discussion we've had this afternoon. I had one comment and one question. I mean, the comment is based on Prof. Tambaya's suggestion that I agree with his viewpoint. I have always felt that Singapore should be a very good sentinel site for getting information from around the region and feeding to whichever international organizations that are necessary in order to take immediate action, because seeing the countries around us with very, very different health systems and different access to laboratory diagnostics, I think we can definitely play a much greater role. The other thing is a question I had. Those of us who are involved in infectious disease surveillance in our institutions, we've always had to struggle with this idea about, we get so much information coming through all the time, and the threshold at which we should alert, our colleagues is always a very difficult question. I've had, we've all had similar experience where we've sort of alerted the clinicians or the administrators, and then there have been lots of roll-on interventions which we initially didn't expect or anticipate or plan for, and some of which would be completely uncoordinated, unregulated, and most unnecessary. So I've just wondered, like with Dr. Piot's experience, how do you actually gauge that threshold? I mean, it just would be interesting to get your insight. Thanks.
Thank you for that easy question. No, I hear you because that's daily life, and I've gone through that myself. And okay, I can give you the formal answer, and so you have an infection, someone who's in charge of infection control in the hospital, infection control nurse, you have a committee and all that. But that doesn't really answer your question in terms of the threshold, for example. And that's where I think you need this very, very intense and continuous interaction between infectious disease specialists, people in nursing, very important, and the lab. And it's not something you can approach in a too formalistic way. And where I feel maybe old-fashioned a bit, but there is still some art in that and some crafts that. But I think that when you can compare countries and systems, and there are major differences. Just as for antimicrobial resistance within Europe, there are huge differences in antibiotic prescription, let's say, culture, practice, and that are then reflected in the level of resistant infections. And grosso modo is the more south you go, the more problematic it becomes. And so it is, but I don't have a clear answer for your particular situation. And when I say it's an amplifier, it's not to blame anybody. It's just the nature of the beast. That's a fact of life. But Paul, you have...
Yeah, I was thinking of picking up on something that you said, which was involving the individuals who are affected by the disease. Yeah. You know, I'm involved with a group in the UK which has received a big grant from the Health Protection Unit. And one of the requirements of their annual review is they have to engage the public in what they do. So perhaps, you know, the answer is actually trying to determine from the community what is the threshold that they'll accept. You know, as you were saying, you know, what we accept has changed. You know, in Semmelweis' time, people accepted the fact that 1/3 of women were going to die in childbirth. And that when he brought it down to 1/6, that was a huge achievement. And that was in Vienna, in the center of Europe. You know, 1/6 maternal mortality of 16% was considered a great achievement. So I think perhaps, you know, there has to be some kind of threshold setting, and that may make things clearer for the practitioners on the ground. You know, if the administration says we can accept one new HIV case, nosocomial HIV case a year, you know, I don't think they'll accept that. In Singapore, it's probably one every 100 years, you know. Whereas hepatitis B will accept maybe one or two a year, you see. So it's a kind of community sort of, Eason, what do you think?
Maybe I take the easy one, HIV. I think any case of HIV in a nosocomial setting would really need to be seriously looked at in terms of HIV. But I'd like to, you know, run away a little bit from that. But I just want to pick up the point where Paul mentions about Singapore, you know, on the crossroad, and we are highly connected, whether, you know, communications or IT or whatever aspect. So I just want to pick up from there and pose a questions to Peter in terms of how would Singapore position itself? Because we know that we are red dots, we are very small, we are right in the center of Southeast Asia, or right in the center in these regions. We are porous in terms of our border control. So we are very susceptible. How then we position ourselves in the global scale in terms of how do we protect ourselves? Do we now need to be better engaged with the regions internationally, be a bit more of the outward looking, or, you know, any other suggestions that you have in terms of how Singapore will play the role in the global health?
Thank you. Before that, maybe one other element of my response to your question. I got very interested in machine learning and all that, and I think that this is going to be an area where through machine learning and artificial intelligence we probably will be able to refine enormously what is a trigger. When are we in trouble, or when are we potentially in trouble? And with of course, it's not an all or nothing. You know, when are the red lights flashing, when it's orange light, and so on. I mean, like the classic risk management. But that will require many different types of information that can be integrated, and we have to feed into that. From what are people saying and thinking and feeling, to what is the lab giving us, and so on and so on. So that, I think, and at the moment it's probably only used at a mega level, but we can probably come up with devices or an app in the future that can help us in my, I don't know, my ward or my unit or treatment unit or my community or my crash or a senior citizen community or so. Now, I'm of course coming back to your question on the place of Singapore. I'm of course biased because I see nearly everything of the global. For me, global is a new term. It's very important. We used to talk, as Paul said, about international health and so on. International is far away. And now and then it will affect us, and when we travel and when someone ends up here, although there are millions of people, in this case of Singapore. Global is here and there. The word global means not far away. We're part of a global community. All of us are special, unique and so on, but at the same time we're part of that community. And I think on a very practical level, it's a matter of, I would say, of security, really, for the country, and that is a few points. One is to know. what's going on and to be in the information loop within real time. I mean, it's like in the military. I mean, you really need to know what's going on in the surrounding countries and also further ahead. Further ahead, that's a service in a sense that WHO should provide, but it depends on the, how to say, the speed with which ministers of health in all the member states provided information, and that is extremely uneven. So I think having that intelligence with surrounding countries and the bigger area is extremely important. At the moment, one of the things I'm doing while I'm here is learning about the history of the region. The big Malaya region and Singapore and everything. And I usually start very early, so a few thousand years ago. This is a region that's unified by seas and by, and so it is, the borders are as artificial as they can be, and people move. And so I think either like we have in the EU now, like we're, as long as Britain is a member of it, of course, but there is access to intelligence. I mean, I'm talking about epidemic intelligence, and in fact, that's the first thing. Secondly, I think being there. Not just wait until it appears on the internet. So I think actively engage with some key countries, particularly the ones that are perhaps the most vulnerable, have the weakest capacity, because it has to be a two-way street. It should not be only in the interest of Singapore, let's say, but also contributing something for that particular country. And, and so while being there, having the intelligence, having experience, and learning, because it's learning in all directions, at the same time building that capacity. Because if, I gave the example of malaria, if Cambodia can better handle malaria, that will be a good thing for Singapore also. That doesn't mean massive overseas development, as it's called in Europe, but being there, I think, is as important, as just having that intelligence. And then thirdly, I would say that's more of the global good. I mean, Singapore is a powerhouse in terms of research, and particularly biotype of research, biomedical research. And I mentioned the Zika epidemic. We need a vaccine. We need diagnostic tests. So that kind of research as part of the global effort is also a contribution. And in all cases, I think it is a win-win, as they would say in the business school, because it benefits Singapore, but it will also benefit others, and that what do you want more? So, but I think that is the new, how to say, spirit now with the global health security, and that is that no country, even the biggest countries, are safe if you're not engaged in this global health security framework. I mean, even a country like the US or a country like China, they're doing that. And some of it is also driven by national interest and power politics and all that, of course. But it is really because they feel alone they cannot do it. And I think that's true for any country. So I really encourage you. But it's not just an emotional thing or nice to do or whatever or humanitarian. It is really in the enlightened self-interest of the country to do that. And that requires some specific budget, some effort, and one that is expandable or expandable when it's needed. Again, when there's a fire, okay, you give a bit more resources. When there's no crisis, you have. But that baseline, that's really very important, and I would put that under security as much as under health.
Thank you very much. Unfortunately, we have run out of time. So if you have any burning questions, please feel free to approach the panelists at the reception later. Please join me in thanking Professor Piot and our other panelists.
I find that we're at the threshold of the tea session later. So before we go out for our refreshments, I would like to take this opportunity again to thank Professor Piot and our panel discussants, Associate Professor Vernon Lee, Professor Liu Yi-Sin, and Professor Paul Tambaya, as well as our moderator, Associate Professor Su Li Yang, for the insights on the challenges faced in preparedness, prevention, detection, and response to infectious disease outbreaks. A very warm thanks to you, our audience as well, for taking the time this afternoon to join us. I'm sure this session has sparked many thoughts and ideas that will carry forward in your research as well as in the clinical care you provide. Now, before we wrap up today's session, I would like to call again upon our school's dean, Professor Chia Ki-sing, to provide tokens of appreciation to the members of our panel as well as to our special speaker, Professor Piot. Professor Chia. Could I commence with the moderator, Professor Su Liang? Thank you. Next, Professor Vernon Lee. Followed by Professor Liu Yixian. Yixian. And followed by Professor Paul Tambaya. We save all the best for last. We would like to present a special token of appreciation to Professor Peter Piot. It's a special memento, yes. Ladies and gentlemen, guests, with that we have come to the end of today's session. Thank you and enjoy the rest of your Monday.